So today we're gonna discuss diabetes in your feet. I am Dr. Stephanie Kane. I am a certified foot and ankle specialist down here in South Florida. I will give you my email address, my phone number, whatever you need. Any questions you have after, you can always reach out if we don't cover something in this call or anything to do with the foot and ankle. So let's break down diabetes a little bit. More than 37 million US adults have diabetes. That is a very large number. And about 1 in 5, they don't even know they have it. So until they actually get the workup or someone brings to their attention, maybe they have diabetes, they may not even be thinking that they have diabetes. And it actually is the 7th leading cause of death in the United States. So it's it's a pretty serious thing to kind of take, a little seriously. In the last 20 years, that number has more than doubled. Diabetes is also the number 1 cause of kidney failure. Unfortunately, lower limb amputation and blindness in adults. So what is diabetes exactly? Just very layman's terms, very easy. It's a disease that you start seeing the changes in the blood glucose levels in your body. So insulin is what helps the glucose get to the cells to produce energy. And when that isn't happening properly, your body's kind of going out of whack, and we can kind of diagnose it with blood tests. Most commonly, the measure of blood test would be your glycohemoglobin, or what a lot of people hear is A1C, and that's a 3-month measurement of your blood glucose levels. The other thing that we do commonly is daily glucose or fasting glucose to kind of see how the body is handling all that insulin and their glucose in their body. So a little bit about diabetes. There are 2 different types of diabetes. Type 1 is usually the younger, it's considered juvenile at times, less than 40 years old. They're insulin dependent, so that means that their body does not make the insulin, and they usually have an acute onset of symptoms. Whereas type 2 is usually developed later in life, greater than 40 years old. It's not always the same, it could be earlier in life. Usually it is, prone to people that have a little bit of overweight. It is something that happens gradually over time. It's not an acute symptoms. And in type 2, your body either does not make or use the insulin well. So with diabetes, there's a lot to manage and take care of, and your feet are equally as important to pay attention to. So how can your feet be affected? 3 easy ways we talk about with diabetics, their feet being affected. One is a decrease in blood supply. So if a decrease in blood supply leads to poor healing. So anytime you get a cut, a wound, a scrape, the healing is a little bit delayed. We see a lot of extra weeks when we kind of deal with that. Number 2 is nerve damage. So nerve damage can come from neuropathy with diabetes. That can lead to a loss of feeling. It can create wounds, complications, and about 50% of diabetics end up having some level of nerve damage. And then blood sugar levels. So blood sugar levels, when the blood sugar is high, it can actually lead to a decrease in healing of simple scrapes, simple cuts, an ingrown nail, step on something, wear a shoe that's too tight, and that ends up leading to decreased healing and complications. When I break it down for my patients, I try to break it down pretty easily. With diabetes, I like to say it's the ABCs. It's important to control your ABCs, so that way they kind of remember. A being that hemoglobin A1C level. That's the blood test we just mentioned a little bit earlier. That's the 3-month overview of your blood glucose levels. Unfortunately, this time of year, it's after the holidays, after Thanksgiving, after Christmas, and it's a 3-month blood glucose. So we usually see a little increase after this time because people, they were enjoying themselves and indulging a little bit. The B of ABCs of diabetes is blood pressure. High blood pressure will put you at a risk for a heart attack, a stroke, kidney disease, all the things we don't want to have happen to us. And then the C is cholesterol. Sometimes with diabetes, we think so much about the blood glucose that we forget about the blood pressure and the cholesterol. Cholesterol is a waxy substance that's found in the blood, and that can also increase your risk of heart attack, strokes, and affect any blood flow. So diabetes and feet. About 15% of diabetics will actually suffer from foot problems. A majority of those patients are type 2, or they have long-term diabetic type 1, the juvenile diabetes. And about 45% of all major amputations of the lower extremity are caused by diabetic foot syndrome. So a regular assessment of your feet is kind of recommended by Medicare. They'll cover you every 63 days, but at least twice a year if you are borderline diabetic, you think you're diabetic, or if you are diabetic. Usually the regular assessment of the feet will include a couple different things. One is a sensory test. So they may touch your feet, check your light touch or sensation. They may check your position of your joints. They may say, close your eyes. Is this up? Is this down? They may check sharp and dull, nothing too sharp, but just kind of poke you with something a little sharp and like a little wisp of cotton to see, can you differentiate between sharp and dull? They'll check the temperature of the feet. They may use a little fishing line. I don't know, it's hard to see. A little fishing line to see if you can feel it. Have you close your eyes and see if you can feel that on your feet. It's called a Semmes-Weinstein monofilament. And those kind of lead to kind of give us an idea of if there's, any kind of loss of sensation. Blood flow will be checked at your visit. This includes feeling for pulses, checking the capillary refill. That's the time it takes when they kind of touch on your finger or touch on your toes and kind of see how quick it goes from white back to pink, or in the nail beds. Sometimes they'll order what's called an arterial duplex or an ankle brachial indice. Those are blood flow exams. The arterial duplex is a non-invasive ultrasound that just looks at the flow to the lower extremity. And the ankle brachial indices or ABI tests, those are non-invasive as well. It's a blood pressure cuff on your arm and one on your ankle. And if they're looking at the toe pressure, one on the toe, and they measure the difference between the blood flow. As we move further away from the heart, the blood flow works a little bit harder to get to our feet. They'll look for any deformities, flat feet, bunions, hammer toes, any kind of bony prominences, anything that may be an increased risk to irritation, rubbing, wounds, pain or discomfort. They're going to check for ulcers or wounds, cuts, scrapes in between the toes. Are you drying between the toes? Is there moisture buildup between the toes? And lastly, they'll probably check for some corns, any calluses. A lot of times we think, hey, I've had that forever. The body's way of protecting that area is to build that callus up. However, with that thickened callus, sometimes under that, a wound can actually form. It can become tender, painful, and a wound can form under that callus. So it's always important even to get some of those long-standing calluses or corns kind of taken care of. So some ways to care for your feet: check your feet every day. If you have someone that you trust to help and see the bottom of your feet, you can feel around, see if you feel anything different. It is hard to see the bottom of your feet. That's why a lot of things end up happening and go unnoticed. Some people will use their camera phone because now everyone has, fancy phones. So they'll kind of put it on a stick or they'll hold it down and just kind of take a picture or reverse the camera, take a look at it. They'll put their camera on the ground, put their foot above it, anything to kind of just take a look at it. Check for any cuts, any sores, red spots, swelling, anything that smells funny. Check your toenails in between the toes. For some reason, the foot, it kind of always gets put on the back burner. But it's important to check the foot for anything, even a little basic, and any dry skin or cracking that can lead to openings, the deep kind of fissures we get can lead to infections. Another thing is wearing white socks can really help. So if a wound forms, you may not be able to see the bottom of your foot, but if you're able to take that sock and flip it inside out and you see drainage or you see blood, something's going on. So to get some help and take a look at that. Washing your feet. So when you wash your feet, wash in warm water. Now, if there is any sensory deficit or you're losing some sense of sensation, it's important to check it with your hand, because just putting your foot in the water, you may not feel that increase in temperature. So it may be hotter than you expect, which can lead to burns, complications. Dry your feet really well. It is so hard, but drying between the toes is so important. So if you get a little long towel and dry between the toes, or if you sit down, a lot of moisture can build up between those toes. And it can lead to fungal infections and deeper infections that we don't want you to have to deal with. keeping the skin soft and smooth. Apply lotion to the feet, any kind of moisturizing to the feet, smoothing out the corns and callus, like we spoke about. Have a doctor, take that down so that way you don't develop any injury below the callus. Don't cut on anything. I have so many patients that come in, they love doing bathroom surgery, but by the time they come in, usually it's further than it was if they came in to begin with. So if you see anything questionable, hanging, painful, go and see the doctor. It's better to get it taken care of earlier on than for it to develop into a complication. And then toenails, trimming regularly, trim them straight across, don't pick at the ingrown, don't trim them into the skin. A lot of times if you're covered by Medicare for routine visits, or if you have something set up with your doctor, they'll trim those toenails for you at your visit. Then going into that, diabetes, it's so important to follow up with your routine foot care. There's a reason why so many diabetics are seen by doctors on a routine basis, and that's because from one visit to another, unfortunately, things can change quite drastically. So make sure that you're following up for those routine foot checks. So preventing foot problems and protecting those feet, wear shoes and socks all the time. Down here we have a lot of people walk barefoot. When you walk barefoot, maybe there was a piece of glass that you broke 7 months ago that you didn't see it on the ground, and you don't have sensation like you did when you were 18 and you step on it. Now you have a foreign body in the foot. It's easier to wear the shoes and socks than to have some issue and have to deal with that issue. Leading into that, wearing good supportive shoes. Giving that support to the foot, making sure that there's no irritations, nothing's rubbing on the foot, nothing's causing any irritations, wounds, pain, discomfort. Some insurances will even cover diabetic shoes and inserts yearly. So a lot of patients are saying, I don't want those ugly shoes. The shoes are all different types now. They're so improved. You can get anything from a lot of different sneaker brands that you would see on the store shelf to, to some thick leather shoes, to boots, to a lot of the sandals. There's a lot of different options. And a lot of times with the diabetic shoe program,
Hold on, we're having a little difficulty there. She had this earlier. One sec. Hang on. 1 second. Ashley, do you,
Yeah, I'm gonna put her in the waiting room.
okay, yeah, let's put her in. Hang on. This happened a little earlier. Let's see. We're gonna bring her right back. Hold on. I think it was that Wi-Fi that she was talking about that was happening.
Yeah.
Hold on.
She's
see.
still coming.
Yeah, I think she's coming in. She's connecting to audio.
She actually she's probably restarting her computer.
Oh, yeah. Yeah. And then, yeah, and in the meantime, if anybody has any questions, you can add it to the chat because we'll get to those ones. I don't, the slideshow wasn't long, so she could open it up for a question and answer. But let's see. She should have restarted her computer before. Nothing like a live Zoom without a little Zoom moment of technical difficulty. So we'll just bear with us just a minute here. She'll be coming back in. Let's see. Is she coming in?
I'm gonna try giving
Still
her.
turning it on.
The what?
Yeah.
Still rebooting, it looks like.
Oh, rebooting it. Yeah. Okay. Well, yeah. So just bear with us. Let's see. We could see if she's coming back in. I wish I had some ad lib notes that I can add about diabetic foot issues. I don't. I usually can ad lib about a lot of things. This one I don't. I don't have any notes on or my own experiences on it, but I'm learning a lot from what she was telling me. Very interesting. But let's see. Hang
I'm
on.
gonna just give her a quick call.
Yeah.
She's
Let's see. Hang on. I see. Oh, let's see.
And her
Um,
next one is also like similar to this, right?
Yeah, next one is in actually, it's in April, and it's on arthritis in the feet. But if anybody has questions today about arthritis, she's definitely can
She's here now.
go back
Oh.
to that one as well, because
Oh,
whatever
here she
you're,
is.
yeah. Steph, can you hear us?
You're on
Hold on,
mute,
you're on
but
mute.
we see you.
Okay, there you go.
I was really trying to step in there for you. I had zero information that I could give
So we're
my.
all good. You guys know
I can talk
everything.
about a foot cramp. All right, go ahead. Sorry about
I don't
that.
know. I don't know when I got kicked off. Did we see these?
Did we see those?
No.
No, I don't think we
All right,
saw
let's
those.
start
You were
there.
just talking about that.
Yeah,
Okay, so we're talking about shoes. Okay,
Yeah.
or feet. So protecting, let me pull up the, let's see. There we go. Oh, I could have, let's see. Okay. So wearing shoes. Are you able, hold on one second. Let me share. I'm getting excited. Okay, everyone can see the screen now and
Yep.
everything. Good.
Yep.
Okay. So wearing shoes that fit really well, protect the feet are super important. Good supportive shoes. You want them to be breathable. You want them to not have any areas that have vinyl or plastic that kind of put pressure or don't breathe. A lot of times, even with good supportive sneakers, the issue is that they have a little kind of lip to them. And even then you can kind of get irritation to the toes or the bunion or the outside of the foot. Some insurances will even cover diabetic shoes and inserts yearly. And so they're not all the ugly type of shoes that we're used to, the big black clunkers that everyone says they don't want. There's everything from a lot of different sneaker brands that you can find on the shelf to sandals, to work shoes, to boots. So it is something, if you have diabetes, definitely talk to your doctor about, because they do come with one pair of shoes through Medicare in a given year. On top of that, they also come with 3 insoles. And so the insoles are made of plastizote. And it is a accommodative material that's kind of squishy and comfortable. And it's made so that way you don't have irritations or pain or discomfort. You want to wear clean, lightly padded socks. We talked about the white socks. Switch them throughout the day if your feet sweat or if they get wet. Don't stay in the same socks. Put an extra pair around, just kind of switch it out. Can prevent infections, can prevent fungus. Also, socks without seams. They also sometimes eliminate that pressure and irritation. So if you can find some nice breathable socks without seams, you also eliminate that kind of irritation. Check the insides of your shoes before you put them on. Make sure there's no objects in there. I've taken a lot of random things out of shoes, especially with diabetics or people with neuropathy. They don't even know it's in their shoe, and then you can see the imprint of a key or a stick or anything they kind of got in their shoe on their foot when you kind of are looking at their feet. So we want to make sure that you're not stepping on anything because maybe you don't feel it. A big thing with diabetes is protecting from temperature. So you do want to protect your feet from the hot and the cold. So we don't have this issue down here, but keep your feet from open radiators. Keep them away from open fires. You may not feel that, and you're living in a cooler environment, you want the warmth, but you may not feel the heat as maybe when you were 18. And so you don't feel that hot, and sometimes develop blistering, 1st-degree burns, sometimes even worse. Lined boots in the winter are a great way to keep your feet warm with socks at night. If you're in a warmer climate, remember, use sunscreen on the top of your feet. When you're on the sand, test the temperature, same thing as the water. Test it to make sure that it's not hot, that you're not gonna burn your foot. The other thing is, it really is best to kind of wear protective shoes when you're out walking on the sand, because there's a lot of foreign bodies, a lot of other things that can happen if you don't, not just the warm sand, but if you don't feel maybe a little stick that you step on, a piece of coral, sometimes it can become even more of a complication. And then keeping the blood flowing. So you want to keep that blood flowing to your elevation can really help. exercises for the foot and ankle. Even small little range of motion exercises can help increase the blood, can increase the flowing. Just take your ankle, kind of spin it and take it around, write the alphabet, pull it towards you with a little resistance band, a towel, a pillowcase. Try not to cross your legs. You kind of cut off some of the circulation when you do kind of cross your legs. Avoid wearing anything really super tight, socks, shoes. Don't smoke. Not here to lecture anyone. I know that's a hard thing to quit, but that does reduce the blood flow to your feet. It can lead to further complications. You'll see, really painful cold feet. And you definitely, if you are going for any of those arterial exams, you don't want to smoke before those exams either, because it will kind of constrict the blood vessels. And controlling your blood glucose. Make sure that it's controlled. You're trying to keep it as low as possible, whether it's through diet, exercise, medication. Same with blood pressure, same with cholesterol. We want to get the best flow to the foot and to every other part of the body. So if something comes up with the blood flow, it may be necessary to see a vascular specialist. Just keep that in mind. Sometimes there are steps that they can take, whether it's conservative or surgical in nature, that can kind of help with the blood flow to the foot. So eating healthy. So everything in moderation, right? We want to control those blood sugars. We want to control the fats that we're taking. We want to check your body weight, make sure it's keeping in this, in a healthy kind of range for you. That's the, the body mass index, the BMI, your weight with your height and everything like that. You want to keep your carbohydrates in check. So you want stuff high in fiber, lower in fat and sugar. You want this good balanced diet. You want to make sure you're getting adequate energy, proteins, fluids, vitamins, minerals. It just, everything in moderation. You want to make sure that you control what you're doing. If you are diabetic and you're monitoring those blood sugars, big pasta meals at night, the next morning you may see your fasting blood sugar is up a little higher. So maybe you cut back. There are nutritionists out there as well who focus just on diabetic nutrition. And so if it's something that you're battling, or you want more questions and answers performed, then that's definitely someone to have to talk with. Exercise. Now, you don't have to be the biggest or the strongest around, but just getting that blood flowing, getting that heart rate up for about 30 minutes a day, it can really help with insulin sensitivity and the requirements of insulin on the body. It can reduce your weight, it can control those lipids, and it can control your blood pressure. So I always had a physician in my medical program that always said exercise is medicine. And we learned so much about, drugs for this and drugs for that. But even just adding just a little bit of exercise to your day can really help. So the daily inspection of your feet. So we talked a little bit about checking your feet daily. What's important? So when you check your feet, do you have broken skin? Do you see an area that maybe is raised that wasn't raised before? Is there an area that is bleeding? Is there an area of pain or discomfort? Is there any redness anywhere? Did you get into a tight shoe, or did you bang your foot? Or did you maybe nick it cutting your toenails? Any redness, any swelling? If there is a area of swelling, is it new? Is it both sides? Is it one side? Can you push on it with your finger and get that imprint and see how slow it kind of fills back in? Or is it swelling that's not kind of going down when you push on it? Is it painful in nature? Do you have any hard tissues, any callus lesions, any pressure spots? Maybe they're not bothering you. Maybe they are bothering you. It's always good to get them checked out. Do you have any black or blue areas? Do you remember maybe getting up in the middle of the night and stubbing your foot? Is your foot cold to touch? Is it painful? And then any pains at all, and where? Whether they're chronic pains that you've had for a while or they're new pains, it's always good to try and get, something kind of taken care of, taken a look at, so that way it doesn't get worse. And that is all of a brief overview of diabetes in the feet. So I know we love questions, so we'll go into that.
Yes. So, yes, there's a bunch of, let's see what we got going on here. So here we go. You can sometimes eliminate the seam pressure by turning the socks inside out. Always did that.
Yes.
Yep. Okay,
Yep, that's a great option too. Yeah, you can take the pressure off. You can turn them inside out. Wear kind of seamless socks. Anything that's gonna kind of give you the pressure. We want to make sure that you just don't get any irritation, any pain, any discomfort.
and compression socks. I know we always touch on this because this is so important. So
Yeah. So,
uh,
and I think you probably typed that when I said avoid tight socks and tight. So compression socks, and I was going to mention that when I just said it, but I figured it was going to come up. Compression socks, meaning, I love compression socks. I love them for venous insufficiency, for swelling, for return of blood flow. You want to make sure, obviously, that it's the right compression for you, that it's fit for your leg. So they will take a measure, and I actually almost brought a measure in here on the desk to show you, but they'll take a measure, they'll measure the calf, they'll measure your lower leg and make sure that's the right one for you. So avoiding tight socks, meaning like just putting on a little Ked or like a Hanes that's too tight for your foot, it doesn't fit your foot. If it's a compression sock that's helping you with medical stuff, definitely wear.
okay. So pedicures, I know there's medical pedicures and there's, other, there's pedicures in a salon, right? So is it okay to have pedicures? I know you talked about that a little bit.
I see a lot from pedicures. I'll put that out there. I see a lot of anything we talked about it previous. I've seen, ingrowns, little infections to bone infections that people have gotten from salons. So everything, you do have to be careful, even the cleanest salon, or you think they're sterilizing things. You never know. I mean, same thing goes for doctors, anything you go, you just never know. With diabetes, some of my patients will come in and they'll have their diabetic foot check. I will cut their nails, I'll do their corns and calluses, and then they'll go for like a polish change, and they'll have, like a little massage and the lotion and get taken care of in that way. Sometimes at some salons, and obviously there's millions of salons that they'll get a little overzealous, they'll pick at ingrowns, they'll pick at skin, they'll cause an infection, diabetic or not. And then yes, there are medical pedicures now too. And so the medical pedicure program is with a certified medical pedicurist. They go to school, they train in the anatomy, in the pathology of fungus, diabetics, ingrown nails, and they're kind of trained to see all those things. And so that is definitely something that's picking up as well. So it may be worth if something that you definitely like, that kind of TLC and that time to yourself, and look into a medical pedicure program. I will say most of them don't soak the foot. It's more like a facial for your foot. They use warm towels and massage. The soaking of the foot, they kind of learn in school, you're kind of just sitting there and soaking. A lot of the bad stuff just are all around the foot. So medical pedicures sometimes avoid that whole whirlpool situation.
Okay. And then Betty asked, what kind of toe exercises for the second and the third toes, each foot, it started with neuropathy for the past year, not diabetic though.
Yeah, so this was about diabetes. Now they're like, unfortunately, neuropathy can get a lot of different people for a lot of different reasons. It is the same sensation, loss of sensation in the foot. And usually it does start in a stocking and glove distribution, meaning it kind of starts at the tips and works its way up like you're pulling a stocking on or a glove. Just the kind of toe exercise, there's not many things to do for toes, obviously, but the most important things are getting increased range of motion. So you can take a resistance band to the forefoot and kind of wrap it. This is a fake foot, obviously. Wrap it around the forefoot and kind of bring it back towards you. You can take the foot and kind of try to grab a towel, a pebble, a marble under it. You can take a little rubber band around around the toes and kind of stretch it out, stretch it in, stretch it out, stretch it in. Sometimes people even take rubber bands and kind of put it on the toe and just kind of pull back, go back. Massage helps increase the blood flow too. So with the exercises, giving a little bit of massage. Unfortunately, with neuropathy, most times you can't go back. It is what it is, but we can keep it from getting worse. Some vitamin B1, 6, and 12, those are neurovascular vitamins. Some people with neuropathy do feel a little bit of change when they start taking like a vitamin B complex, or they load up on 1 or 12. So those are all kind of good things to kind of keep in mind, especially if it just started within the past year. We don't want it to get any worse.
Okay, and what about Cindy? Cindy has neuropathy, but also burning feet. Anything good for like that burning feet?
So with the neuropathy, the burning feet, and a lot of the nerve discomfort, there are a lot of different topical creams that you can try to put on. Some people do end up like the vitamin B, and some people do end up on pharmaceutical grade drugs, and they do see relief. It usually acts up at night too, which is no fun. We want to go
Yeah.
to sleep, we want to rest. But it's definitely something to keep in mind. There are a lot of different creams. There's compound pharmacies that will put together special creams with different types of stuff that will cover the neuropathy and the burning and the pain. And so definitely worth talking to a doctor and trying to see what works best for you.
Okay, and then Gwendolyn last, she asked, what are some exercises maybe for someone who uses a walker, who's borderline diabetic, and sits for long periods of time?
Yeah. So, and I will send an exercise list out with just a whole bunch of exercises for the lower extremity. I think we've done it in the past, but that way we have it. Sit down. Obviously, you don't have to be getting up and running a marathon. Get those ankles moving, get the blood flowing. You can take, do I have a foot in here that bends? No. You can take your ankle and just bring it up towards you, hold it for 10 seconds, bring it down, bring it up towards you, hold it for 10 seconds, bring it down. Take that foot and write your name. So we got Gwendolyn, we got a G, we got a W, and that ankle's going to be moving. We got an E, we got an N. Or write the alphabet. You go A and you get that ankle kind of moving. You can do leg pumps if you're able to. You don't have to necessarily get your leg all the way up high, but you can get some leg pumps. You can move the foot up and down, do a little leg push. Even now times they have cycles where you can kind of put under your desk and you can kind of just cycle, or under your chair and just kind of cycle. Good to get the blood flowing. And so all those kind of things, anything you can do. Now, don't forget the upper body. You can take some weights and you can do some arms. You don't have to get up and to get the body moving and get the blood flowing and get your heart rate up. So definitely anything you can kind of sit down, you can do, get the blood flowing.
Okay, and so Nancy was told that she has what's called type 1.5 diabetes. Can you add any ad lib to that?
Yeah, so they definitely, now there's always type 1, which was always considered juvenile, which they dropped the juvenile because it's not always in kids now. And then type 2, and then now there's a subset that they're really calling type 1.5, which is usually like a subset of type 1. Some agencies recognize it, some don't. They're trying to fill the gap between the two of them. It's more considered latent autoimmune diabetes in adult, and what it is it's more of an autoimmune process of type 1 diabetes, if that makes sense. So what happens is your pancreas, which one of your organs, stops kind of producing the adequate insulin, and usually that kind of slows the insulin producing cells in the body. And then unlike type 1, plain type 1, you don't need insulin right away. A lot of times it'll build up, it'll be a little bit more chronic. You won't need it right away. So that's that, but it is the same process as type 1. That's why they're kind of putting it as a subset as type 1.5. If you're not quite type 2, but you're not quite type 1. And those with type 1.5 usually are diagnosed older. I think it's about after 30. So usually the type 1 is diagnosed in kids. And so your body starts to kind of like, the pancreas starts to slow down. Initially your pancreas produces insulin just fine. And then unfortunately, as you age, as everything goes on, the insulin kind of drops off with the pancreas.
Okay. So for B complex vitamin, what do you recommend? A 500 strength or 1,000 strength?
It depends on, well, you can do 1,000 straight up, as long as all of your lab work and everything, you don't have like a really high level of B12, which is one most common one that they check. I definitely would talk to your doctor in terms of what levels would work for you, but Well, a lot of times when I start my patients on it, I'll start them at 1,000, as long as I don't see anything in their labs that kind of vary.
Okay. And so Cindy's on a high dose of gabapentin, but it messes with her head, and she worries about the long-term effects.
Yeah, so gabapentin is one of the most common drugs that is kind of prescribed for neuropathy. It is its own drug class. It's the only drug in its class. It's a gabanoid. So a lot of times when people don't do well in gabapentin, they will switch them to a different drug class. Sometimes they are antipsychotic medications and whatnot. A lot of the side effects are drowsiness, tired, dizzy, not feeling yourself, nausea. It can change your moods. Dry mouth, blurred vision. If the gabapentin isn't working for you, it is worth, one, maybe getting a nerve conduction study, see what's going on with the nerves, but two, also maybe changing the drugs. There are also implantable devices now that are very high success, that they like a nerve stimulator they'll implant in, so that way you can the idea is to get off the drugs, the pharmaceutical drugs, and get the relief through the nerve stimulator.
Okay. So Janet asked, would a vibration plate take the place of your movements while sitting? Since she works from home, she's sitting a lot. She does the vibration plate in the morning, mid-afternoon, and evening.
Yeah, a lot of those vibration plates have become more popular recently. I think they went out and they kind of came back. They work to kind of increase your muscle strength. And so that can sometimes aid with weight loss, and kind of where you're sitting there. So there is movement and their muscles are getting these kind of micro movements to them with the vibration. So I wouldn't say it necessarily increases all the movements, because the range of motion you're not getting as much with the vibration plate, but you're at least getting some muscular movement. So you're definitely getting that kind of work, and it can help with reducing body fat, with your insulin resistance, and kind of helping with that muscle strength as well.
Okay. So let's see. I think that covered the chat questions. Does anybody want to have a question, raise hand or add anything in the chat? Let's see, anyone? And this chat just came, fungus, toe fungus, anything to help with that, to get any from not spreading? Tea
Yeah.
tree oil or?
Yeah, so fungus is so fun to deal with. So the toenail itself takes 9 months to grow out. Sometimes 12, depending on how quick your nails grow. Toenail fungus, you do have to treat for about 6 months. So you have to treat it kind of consistently. We treat it in 3 different ways. One, there is an oral pill that you can take to kind of help with the fungus. It does process through the liver. Not everybody's a candidate for it. I personally do liver function tests with blood work to make sure that everything's going well. It's usually a 3-month course of that drug. Topical is probably the most common, meaning you paint on an antifungal onto the toes every day. You work it into your routine. You put it next to your bed. You put it next to your toilet. You put it next to your toothbrush, next to your shower, something you do every day. And you just work it into your routine. It's like watching paint dry, because it takes a long time for the nail to grow out. But if you keep up with it, you will see results. The nail actually starts to grow below the nail bed, about almost 2 millimeters. It's called the nail matrix. So it takes a couple months to even see that clean growth. So a lot of people give up, or they don't do it long enough, but definitely a lot of the topicals now will kind of help with you. And then the other way is laser. Laser is not covered by insurance, but it uses laser to go in, kill what's called the dermatophytes, the cells of the fungus. And then as it grows out, usually the laser treatments are done once a month. Even then they kind of, I'll have my patients do the topical at the same time. So they invest in both ends of it. The natural tea tree oil, jojoba oil. I have a patient that swears by Vicks. Yeah. I have a patient that swears by Vicks. I haven't seen the fungus go away, but it hasn't gotten worse. But there definitely is a lot of different stuff floating out there. But definitely if you're going to treat it, it's not like a 1 week and you get a result thing. It is a long thing. Now, on the flip side of things, it's the same kind of fungus as athlete's foot. So if you're treating the toenails and you have a little fungus in between the toes or on the bottom of the foot, then it's just going to keep sharing back and forth. So it's important to kind of see the doctor, see if they can diagnose with both. So that way you can kind of treat both at the same time. And then spraying your shoes with an antifungal, antibacterial spray, cleaning your shower, bleaching the shower, cleaning the shower, wearing shoes at pools and gyms, and floors that you kind of share with other people. So that way you don't pick it back up again.
Okay. And yeah, we're not asked, we're going to be sending a recap with all the slides. So we will get that. She was asking about that one slide regarding circulation elevation. So we're going to be sending that in a recap after this to your email, and you'll have the full presentation that Dr. Kane showed. But I do see Cindy. Go ahead. I see your hand up.
Yes, thank you. Good morning. Wonderful information. Thank you so much. I have neuropathy, and I also have a venous insufficiency, for which I have been seeing a vein specialist. I wear compression stockings. My question is, how long do you recommend during the day wearing the compression stockings? Of course, I don't wear them at night, but during the day, what do you recommend?
Honestly, easiest to get the compression stockings on first thing in the morning. No swelling has set in, your feet are at their optimal kind of level. Get them on first in the morning and wear them as long as you can tolerate. A lot of patients will wear them just all day long. As long as the compression is not cutting off circulation or increasing the nerve discomfort, it just helps as you're up and about. It helps that return of the blood flow through the veins. Now the arteries have that easy job, and they bring the blood down, and they have they work with gravity. And so the blood gets down to the toes. Now those veins, they have valves, and over time they may stay open. They may open a little slower. They may close a little slower. And so the blood pools in the lower extremity. The idea of compression is that it helps pump that blood back to the heart. So if you can tolerate wearing it all day, it's the best thing while you're up and about. And it's best again to get them on first. It's easiest, I guess, to get them on first thing in the morning. Now, are you wearing thigh highs?
Up to below the knee.
So I like at least up to below the knee. Even thigh highs is even better sometimes because you get the blood even going up even higher. So the higher the compression, the better. Listen, in South Florida, if I can get my patients to even wear compression to begin with, it's good. But compression definitely does help with the return, helps with the swelling, helps with tenderness, can help prevent wounds that form from venous insufficiency. So it's definitely a great thing to use.
Also, one other question. I have a couple of pairs, so I alternate. How often do you recommend, wearing, before, because I am alternating, I'm not wearing the same.
Yeah, so it depends. So it honestly depends on which type of compression you have, the tightness of the compression, what the material is. A lot of them, I would recommend hand washing and letting air dry.
Yeah, that's how I do it. Yeah, it's exactly how I do it.
Some of them are stocking material, and then other people's have like sock material, like a compression sock. So if you start seeing elasticity kind of increase and you don't feel like you're getting that, you may be due for a new pair. They don't last a lifetime, which is unfortunate. But so it is good that you cycle through, you're not overusing them, and then kind of wearing them out and still using that one.
Thank you so much. This was a wonderful program. Thank you.
So another question. So with the bunion, anything to do besides surgery for pain, when you're wearing the shoes and the bunion comes out of, it's really, that's like a tough one. Yeah.
Bunions are hard, because once you kind of have the deformity of the bone, and a bunion is a 3D deformity. Do I have a bunion foot here? It's a 3D deformity of the bone. And so this foot's pretty straight, but what happens is that this bone, the first metatarsal, starts to fall out and rotate. So these little bumps kind of fall into the inside and the bone falls out. once you kind of have the deformity, it's hard to go back without surgery. It is a functional deformity. However, we can kind of prevent it from getting worse. And how we kind of prevent it from getting worse, an orthotic can help. If you see this foot and where like the arch kind of sits on the orthotic, this joint right back here has motion. And so if it takes a little pressure off the bunion, we can prevent the bunion from kind of getting a little bit increase, more range of motion, more work. The other thing is spacers. Bunion spacers can help. This is one type of one, but how they help is they kind of they go on and they're going to space out the area. This is for the opposite foot, so it's not right, but they'll kind of space out the area and keep that bone away from the other toe. So the first toe away from the other toe with the spacer in here. This one has a silicone pad to prevent rubbing on the side. And that kind of will kind of help keep it in place so it doesn't start to deviate even more over. Unfortunately, a lot of times people do end up in surgery. I say surgery itself is painful. I love to do surgery, but surgery itself is painful. So if it's just a cosmetic thing, a lot of times with bunions, you say, it is what it is. If it's bothering you, causing pain, causing wounds, causing irritations, it's inhibiting your day-to-day lifestyle, your shoes, you can't get into anything, that sometimes is the best time to kind of be like, hey, let me do something about it. But in the meantime, splinting, orthotics, exercising, range of motion exercises can help prevent the progression of it.
Okay, perfect. And then, the good old toe cramp when they totally get whacked out and you can't, it's good to walk on it. How do you, it always happens at night, right? So, I mean.
Yeah, so usually it happens at night. It's caused by a couple of different things. We talked a little bit about venous insufficiency a couple minutes ago. Venous insufficiency can lead to cramping of the foot. So sometimes the compression will really help eliminate that cramping, whether it's at night or during the day. The hydration is a hard one. Dehydration, when your body gets low in those fluids, the electrolytes, your muscles are vulnerable to spasms and cramps. It happens to athletes, it happens to non-athletes. What happens is that we don't hydrate as much because we don't want to be running to the bathroom all night. So at the end of the day, we start to kind of get a little bit lower in fluid, lower in those electrolytes, and our muscles kind of act up because they're getting that tightness. They're not hydrated. The other thing is vitamins. Magnesium and potassium are two of the big ones. If there's a imbalance of those vitamins, then a lot of times it can lead to cramping because of the way the messages are being sent through the body. If you've done a lot during the day, you're tired, you just overdid it, that also can lead to cramping in the foot. It could be coming from the lower back sometimes as well. Spinal stenosis can cause some cramping in the foot. And then blood flow is a big thing. If you have an issue with blood flow, we talked a little bit about it. Sometimes getting that kind of worked out, whether it's arterial or venous, can kind of give you that answer of of the blood flow and the cramping of the foot. So first thing would probably be hydration. You're not going to love me when you get up to go run to the bathroom. A lot of patients also get relief from tonic water. So the quinine and the tonic water can help with some of the cramping at night. So they'll even just have a little of the tonic water, diet tonic water before bed, or they'll eat a banana before bed. And then sometimes it's literally just your position. So poor posture, pressure on certain areas, the way you're sleeping, it could lead to kind of contributing to your nighttime cramping. So, if you want to make sure that you have good, you're not cutting off any circulation when you're sleeping. Some people even put their legs up on a pillow or a wedge while sleeping and they see a decrease in the cramping. So definitely there's a lot of different reasons. It's good to kind of, when it happens, be like, hey, what did I do today? What didn't I do today? And figure out what your reason is.
Okay, so Marcia asked, what can you do for osteogenome syndrome, the extra bone in the back of the heel?
Os trigonum syndrome. So
Yeah.
an os bone is an extra bone. The trigonum is located this one is on an ankle, but it's located right back here, and it can cause a lot of impingement. So when the ankle is moving, it can cause a lot of impingement back there. Now, it depends. Sometimes the bone is super big. Other times it's a small one that just kind of is getting that kind of pressure back there. Sometimes it's due to trauma. So if you had a traumatic injury, you had a fracture, you had a fall, but it just becomes pinched in the back of the ankle. It can cause that pain, that tenderness right in the back of the ankle. Honestly, most times when we treat the inflammation, it really improves without surgery. It could be injections, it could be an oral anti-inflammatory, orthotics. If it doesn't kind of get better with conservative treatment, a lot of times we'll go in and actually remove the scar or the inflammatory tissue around there. And so that way it'll give you back that kind of extra foot motion. It's not really necessary bone. So it's just kind of, you got a bonus in life.
Right, right. And a runner's toe or something when the toe turns black and falls off because I guess of the pressure hitting when you're running, is that what that is?
Yeah, so very common that runners get purple black toenails from hitting the shoe. Even if you're wearing the right size shoe, it's not too, you just, the kind of running, you kind of get all that pressure. It just takes a lot of stress. So that toe repeatedly rubs, slams into the shoe, and it really stresses the nail. It can cause bleeding under the nail, which looks black. Now, when we get bleeding under the nail, we call it a subungual hematoma. Sub meaning under, ungual meaning nail, and then hematoma is collection of blood. Research says if it's greater than 25% of that blood in the nail, it's best to remove the nail and kind of start fresh. A lot of times it will go away on its own. It's kind of important to make sure that you have your nails trimmed, that you're not getting certain pressure in certain shoes. If the nail is lifting from the nail bed, you want to have it removed for sure. It happens again and again. Now, if there's trauma that happens further back in the toenail matrix, then sometimes that can cause the nail to be permanently damaged. And so it may grow back thicker. Also, when you have that trauma and the nail lifts, it gives a route for fungus to kind of get in. So you want to make sure that you prevent the fungus as well. But it will heal. Like I said, the big toe takes about 9 to 12 months to grow out. The little toes take a little bit less, but definitely you may be looking at a year before you have a new nail again. And most people who are running or doing activity, they're not waiting a year to do activity again. So it's kind of a repetitive cycle.
Okay, and the best, I know we covered this because we did an entire thing on the shoes and sneakers and things like that, but to recommend like the best, most comfortable shoe or something to wear that's, in your opinion, something that would be great for the, for the foot so that, most
So
comfortable.
if you're looking for like a sneaker, a lot of honestly it's hard because now we do so much, stores are closing down everywhere, we're doing so much shopping online, so it's very hard to go and like physically put something on your foot and feel what's best for your foot or be fit for your foot. But if you're looking for a sneaker, a lot of the big brands that people love and have really good results with and have the support would be Asics, New Balance, Hoka, Brooks, and those are a lot of different running shoes or kind of supportive shoes, walking. It is important that I don't know if anyone sees these anymore. These guys, the
God, yeah.
the Brannock devices.
Like Buster Brown, yeah.
Yeah, I mean, I haven't seen them in the
Really
shoes.
dating myself with Buster Brown, but yeah.
But you'd be surprised how many people haven't been fit for a shoe in a really long time and they're wearing the wrong size. And so if you find somewhere or you go to the doctor and they can measure you for your right size, it's not just length. I mean, these guys were created for a reason and they have the arch length as well. This side is arch length. And then this is the length of the foot. So maybe you sit at a 7, but your arch length actually shows that you should be in an 8. So when you're stepping down, you're actually almost, an 8 is a better size shoe for you. And then it also tells you the width. And so those are also important, just getting refit for shoes. I can send out a shoe list again too. It has everything from work shoes to sneakers to even sandals with some good support. Dress shoes and whatnot. And that way it's not inclusive. There's a lot of brands that may have been left off on there. So you can always email me. We can talk about shoes. I love shoes. And we can go that route as well.
Okay. That would be helpful, definitely. And Cindy did add in that she uses the Juzo brand, I guess the compression, 2030 for about 4 years now.
Love it. Yeah, I
That's-
like the Juzo brand 2030, that's a good tight compression. She should be getting some good return from that. And 4 years is a nice long time to use compression.
Yeah. And what about flying with the compression? Is there any particular kind when you take a flight, they say to sometimes do that?
Yes, flying or traveling, even sitting in a car for long. I honestly, I'm a very bad patient, but if I'm a good patient, even the days I'm on my feet all day. If I remember to put my compression socks on, just you're going to be up and about on your feet. You're going to, you're going somewhere. You're going to be doing a lot of activity. Compression is a great option. When you fly, you want to make sure it's at least 15 to 20 milligrams per mercury. That 20 to 30 that Cindy wrote is milligrams per mercury, mmHg. So 15 to 20. You want to pop the bomb before the flight. Still important to, I'm not one who gets up on a flight, but at least pump your legs. So when you're in, you're sitting in the chair, you're just hanging out there. Now you're all little sardines because everyone's stacked up on everybody, and just move your ankles up and down, grab your calf and kind of squeeze your calf, or just pump that. You want the blood flowing. You want to try to prevent blood clots, even swelling. You're going to notice that swelling when you get off the flight, regardless. It's just, we get dehydrated in the air. And on top of the blood just doesn't return the way it is. So any compression on a flight is absolutely awesome. Doesn't have to be a specific, it could be a stocking, whatever works for you.
Okay, that's great. Cindy just wanted to add, go ahead. If you want to unmute Cindy, go ahead.
Yeah, Stephanie, that's really very, very helpful about the plane. And also I noticed also sometimes at night, my feet will swell, and that's when I take the compression stockings off. I had tried the lesser brand, the lighter ones, and I actually found them more restricting, and I went back to the 20 to 30, much easier to put on and much easier to use.
Oh, for sure. If I should say this, if swelling persists, it's definitely worth getting a vascular look. Sometimes people do need lymphedema therapy, and sometimes there's even something else going on with you. So swelling we didn't talk that much about it on this call, but swelling to the lower extremity can sometimes be something more than just, hey, it's a little swollen. Our legs do tell us a lot about our body and a lot about our health. And so you may need to see a cardiologist. You may need to see a vascular specialist. So definitely swelling to the lower extremity is not something to kind of write off. If it's one-sided swelling and your leg is red hot and swollen, definitely see the doctor. Okay. It may be blood clot. That's how a blood clot usually presents. So that's why we kind of pay attention to swelling too. Is it one side? Is it two sides? Is it pitting? Meaning that when I push on it, does it stay in? Is it with venous insufficiency? Is it from a trauma? So swelling is definitely our body's way of saying something is going on. And sometimes it's as simple as venous insufficiency and wear some compression, and sometimes it's as much as, hey, something more is going on and we need to take care of it. And sometimes compression is contraindicated, meaning that we don't do it with certain conditions. So if you notice a new onset of swelling that hasn't been treated, definitely have a doctor kind of treat it and tell you how to treat it.
Thank you very much. That's very helpful. And you would suggest the vein specialist as opposed to well, I do, take care with a cardiologist. So I am in touch, and I do get regular checks with that. But I guess to speak to the vein specialist would be a good place to start.
Yeah, so now it's hard because there's like cardiologists and there's interventional cardiologists, and then there's a whole bunch of different levels. So there are some doctors who will do all of the above. So your cardiologist may be able to do everything under their roof. So I would talk to the cardiologist first and kind of go from there if that's who's been treating the lower extremity. But there's specialists for everything now. And so it's kind of, it's a fun place to kind of play around. But a lot of times, a lot of doctors will do things, or they'll be able to kind of guide you to who to go to in your area.
Thank you so much, Dr. Kane.